Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even fewer are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Good afternoon. I'm John Langelo. I'm the president of Northeast Ohio Medical University. It's my pleasure to welcome you to VITALS. VITALS is a nationally broadcast open forum brought to you by Northeast Ohio Medical University in partnership with University Hospitals of Cleveland. It's a chance for us to hear from national leaders who are using the tools of VITALS: value, innovation, technology, advocacy, leadership in service to transform healthcare and improve health for our communities. I'm pleased to be able to introduce today's speaker, Mr. Lee Vermeulen. Lee is the Executive Vice President and the Chief Executive Officer of the American Association of Colleges of Pharmacy. It is the national organization that represents pharmacy education in the United States. The AACP is a leader in advocating for and improving education and training for its 142 institutional members. They represent about 50,000 students, and of those, 5,100 graduate level students in the United States. Mr. Vermeulen was also an executive leader at the UK healthcare program at the University of Kentucky, and also at UW Health and University of Wisconsin-Madison. In those positions, he led transformative change by directing improvements in quality using data-driven approaches to improve both healthcare outcomes and reduce costs. Please join me in welcoming Mr. Lee Vermeulen.
Very much. Thank you, President Langelo, and thanks to all of you for coming. I'm going to give you a quick overview of my presentation, and I'm really looking forward to the conversation we can have afterwards. I'll give you a little bit more detail on the American Association of Colleges of Pharmacy, the association that I'm honored to work for, including this fine university as a member. Talk about some of the challenges that we're facing in pharmacy education and pharmacy practice today in the United States, some opportunities for improvement, and then again, we'll have plenty of opportunity for questions and discussion afterwards. So AACP, the American Association of Colleges of Pharmacy, was founded in 1900. So we're coming up on our 125th anniversary. We represent 143. Actually, we had a new College of Pharmacy added since my bio sketch was updated last. I'll have to fix that. 143 accredited colleges of pharmacy in the United States. And for those of you who are not in the pharmacy world, it's important to recognize that this has doubled in terms of the number of colleges of pharmacy in our country just over the last 10 to 15 years. So a significant increase in the number of places where individuals are training to become pharmacists and pharmaceutical scientists. We represent about 70,000 faculty members, 53,000 students in professional programs, and of course, our graduate students in the pharmaceutical sciences as well. Okay. Oh, there we go. Our mission is to advance pharmacy education, research, and scholarship, practice and service in partnership with all members of the healthcare system and stakeholders to improve health for all. Our vision is a world of healthy people through the transformation of the health professions education. So we work very closely with the other schools of the associations of the schools of the health professions, and really with colleges of pharmacy, medicine, nursing, dentistry, veterinary medicine across the board to achieve our mission. Just a few words about our strategic plan. It was just approved this past July by our House of Delegates for our association. We have 4 different pillars in our strategic plan for our association and for the members of our association, our colleges of pharmacy, each broken down into the 3 main pillars of the missions of our members. So education, practice, research, and scholarship. But then we also have an outreach and engagement pillar, which is really critically important. So over the next 2 years, our association will be working in a wide range of different areas. The first one on the list, though, is where I'm going to spend a lot of my time, and I'll talk more about our crisis today with enrollment in colleges of pharmacy and our faculty shortages. We also have objectives around increasing member engagement, how our members are engaged with our association and working together collaboratively to train the next generation of pharmacists. Enhancing our advocacy efforts. We're a 503c3 association. So for those of you who are aware of nonprofit status, we're not allowed to lobby, just like most of our colleges of pharmacy have limitations on the lobbying they can do. But that doesn't mean we can't advocate. And we'll talk a bit more about our advocacy role in a few minutes. Being in Washington, D.C. is a great place to advocate, not only for pharmacy, but for healthcare in general. And of course, promoting DEIAB efforts throughout our profession and in education as well. On the education front, we'll talk a bit about some of the innovation that we're working towards in competency-based education models. And we're focusing on clinician and student and faculty well-being as a critical part of making sure that we're treating ourselves well as our patients. In practice, we're advancing practice transformation, particularly in the community pharmacy setting. And I'll say quite a bit about that in a few minutes, and our focus on a scope of practice regulatory model, which will change the way pharmacists are regulated in our country. And then finally, a significant amount of work going on in our colleges of pharmacy across the country. 3/4 of our faculty are involved in research in some way. And we have 1/4 of our strategic plan focused specifically on scholarship and expanding programming for science faculty and our member institutions. We're facing a wide range of problems and challenges in colleges of pharmacy. These are not unique to the challenges that we see in colleges of medicine and colleges of nursing, colleges of dentistry, but I'm going to talk a bit about where we're struggling today in pharmacy education. Curricular overload, some people call it curricular bloat. I like overload as a term. Simply too much to learn in the 4 years that we have our pharmacy students in their professional training. And this is a problem that will be continuing as more technology advances, as more innovation occurs in healthcare. We have to find ways of making sure we can deliver as much knowledge as possible in the short period of time that we have our students. We have a professional identity in pharmacy that's very much tied to a business model. It's very much tied to dispensing and receiving money back from insurance or from patients for the dispensing of prescriptions, as opposed to the biggest value that pharmacists provide as caregivers in the healthcare system. We need to change our value-based structure in pharmacy from being a product-oriented to a service-oriented model. We're working very hard to do that. I'm going to talk more about the workplace conditions. Many of you get your prescriptions filled, perhaps, or your family gets prescriptions filled at a Rite Aid or a Walmart or a CVS or a Walgreens. And you can see what the workplace conditions are for the pharmacists. A full half of our graduates from pharmacy schools in the United States practice in that setting. Workplace conditions is a significant concern, and it's having a big impact on how we're able to recruit young people into colleges of pharmacy. Talk more about that in a second. And then finally, I just to reiterate our biggest challenge today, the one on the very bottom, having a declining enrollment in colleges of pharmacy. And let me share some data with you. So we need about 14,000 pharmacists every year to graduate from our 143 colleges of pharmacy to fill the spaces we have in our profession, from retirement, from those leaving our profession, from those leaving practice. We need about 14,000 new pharmacists a year. We will be graduating this year just a little over 10,000, not 14,000, but 10,000. We enrolled last year just a little over 10,000 pharmacy students. Where our numbers this year are up a bit, actually, which is terrific. We saw about an 8% increase in applicants to colleges of pharmacy year on year for the classes that entered entered training in the United States this year, our fall 2024 entering class. but that's still not going to be enough. And as we continue to see a decline in the number of enrollees, we are thinking of this as a public health crisis, where patients are going to be living, families are going to be living in pharmacy deserts, in areas where there aren't pharmacists, there aren't pharmacies to have their prescriptions filled. And we see that as an emerging public health crisis that we need to address. Now, why is that happening? Well, it's important to recognize that this isn't just a problem with pharmacy, and it's not just a problem in healthcare in general, but across the board in higher education and universities across our country, we're seeing declining enrollment. Some of that is demographics, lowering birth rates. We have one of the smallest high school cadres of young people in high school today than we've had in decades, and that's going to continue to decline over the next 2 decades. So there aren't as many people entering higher education. But we have a problem demographically, we have a problem psychologically. We have a lot of young people who look at higher education and are questioning the cost of higher education and indeed the value of higher education, saying, I don't know why I need a college degree to be successful in life. We have ample evidence that those with college degrees do better financially over their lifetime, and that's not an argument that is as compelling as it once was. So we're looking at a decline in overall higher education. We're also seeing declines in most areas. Medicine, in dentistry, we're finding great numbers, but in pharmacy, in nursing, in PT, OT, in most other health disciplines, we're seeing the kinds of declines that we're seeing in pharmacy. Some of that has to do with the impact of the pandemic and the changes that the pandemic played in how people view their role as healthcare professionals and the desire to become a healthcare professional. But in pharmacy, we have some fairly specific problems. The length of our program, the cost, our debt to first year salary ratio is going up. And that's a very important marker for people who are thinking about, do I want to become a doctor? Do I want to become a nurse? Do I want to become a pharmacist? Do I want to be in the STEM fields or in healthcare in general? That's a number that they look to. And it's an important number for us to focus on. But as I mentioned, the biggest challenge we have today in pharmacy, and we have ample evidence of this within our profession, looking at how our workplace conditions are affecting how young people view the profession of pharmacy. For many young people, the first experience they have and the kind of the driving experience they have to decide to go to pharmacy school is what they saw when their family members or they got a prescription filled at a community pharmacy. And they see that workplace and they see those workplace conditions not being very desirable. We do a study, we operate the Pharmacy Workforce Center for our profession out of our association. We do research projects every 2 years to look at the emergence of our workforce and how many and how they're doing. One of the things we found in this year's study was when we look at the engagement of pharmacists in practice by setting, how engaged are they in their profession? How satisfied, how happy are they? How likely are they to stay in their profession? The lowest engagement of all different areas of pharmacy practice, in hospital, in research, in all different areas, and then looking at community, the lowest engagement we have are corporate community pharmacists, CVS, Walgreens, Rite Aid, Kroger, Walgreens. The highest engagement are pharmacists who work in independent pharmacies. These are the pharmacies where they're owned and operated by pharmacists. They're doing exactly the same work, filling prescriptions, counseling patients, caring for patients, vaccinating patients, exactly the same work. Highest engagement, independent, lowest engagement in the corporate world. We're working very hard with our corporate partners to make them understand that their business model is not going to be tenable for long if this is how they're going to continue to treat our graduates. And I'll talk a bit about how we're working with them to move this forward. We believe we have an awful lot to leverage in pharmacy. We are leveraging our proven value, our contribution to the care of patients. 7 out of 10 COVID vaccines were given by pharmacists or pharmacy technicians. Pharmacy got our country out of the pandemic. Now, a lot of pharmacists just ignore that fact, drive right on by it. We're not driving right by that. We're pointing out the work that we can do to contribute, particularly in primary care settings, in those community pharmacy settings. We are the #1 most accessible healthcare professional in all other fields. And that access to care is something that our patients demand. We're working in partnership with state boards, state associations to prove and really argue that point about the strength of pharmacy moving forward. And we're taking an evidence-based approach to resolving practice issues. Most of that work is going through a division within our association called the AACP Transformation, the Center to Accelerate Practice Transformation and Academic Innovation. It's a relatively new group within our association, staff that are working to examine different ways we can improve practice, and by improving practice, enhance and transform pharmacy education. The biggest areas that we're working on in this space have to do with our community pharmacy practice setting. We sponsor and host the Academia Community Transformation Collaborative, or ACT Collaborative. It's a group of pharmacy students from around the pharmacy schools from around the country, working with the Community Pharmacy Foundation, with CPSN, which is a group of independent community pharmacists, and with several other pharmacy associations to enhance and focus our attention on increasing the role, expanding the role, re-envisioning the role of the community pharmacy through an academic approach. We're together, we're uniting community pharmacists, particularly those that work in colleges and schools of pharmacy, mobilizing our community pharmacists to be enhancing their practice and driving practice forward and amplifying the messages for that collaborative goal of supporting transformation of pharmacy practice in the community setting. We've got 3 kind of signature programs that we're working through right now, again, to demonstrate to both pharmacy students and those interested in pharmacy going into community pharmacy, as well as those that are in practice today, some critical projects and activities within the community setting. We have a transformation badge, which we're offering, which is an educational process that leads to a badge in community pharmacy practice. We're expanding our community pharmacy scholars program for pharmacy students who want to go into community practice. For many years in pharmacy schools, we push the postgraduate residency training and career paths that lead into the hospital setting. It was a big area of need, of interest, and it reached a point where many of our faculty started telling students, if you want a great career, you need to do residency after your Doctor of Pharmacy degree, and you need to find a clinical practice in a hospital. Yet half of our graduates go into community practice. So the messaging that we're sending to those students is that somehow that career path, direct to practice after going to PharmD school, is something less than what they could be doing in other settings. And we have to change that narrative. And that narrative is being changed within our colleges of pharmacy to say, community pharmacists see more patients on the first 15 minutes of every Monday than most hospital pharmacists see in a month. And if that isn't clinical practice, I don't know what is. So we're pushing to have our scholar leaders understand the value of clinical pharmacy in the community setting, and we're using that to leverage the practice as they're graduating and moving into better community practice settings and better community practices in general. We also have a community pharmacy centers of excellence program where we're inviting our colleges of pharmacy to apply and enhance the work they're doing in community pharmacy, pushing more research into the community pharmacy setting, which is a huge opportunity for us to move clinical trials into that community setting, particularly in areas where we're seeing underserved patients. One of the most important things we think about in clinical trials isn't just the research that we do in that setting, but rather the amount of care we have to wrap around a patient who's involved in a clinical study. And when we look at that care they're receiving, extra lab tests, extra attention from physicians and pharmacists and nurses, the places they don't get that kind of opportunity are in areas of underserved, in rural areas, in inner city areas. Not only do we find diversity problems in clinical trials as a problem, we also see the lack of access to care being driven by the fact that we don't put clinical trials in those settings. We need to change that, and we're using clinical pharmacists in the community setting to make that happen. So these are some things that we're recognizing our schools and colleges of pharmacy for doing in terms of their recognition program for centers of excellence around community practice. Just want to mention a few other things that we're working on within AACP and our members are working towards. I mentioned advocacy is a really critical role. We're increasing the amount of advocacy work that we're doing. We're working very hard at the state level. Now, I live in Washington, D.C., and that's where my association is headquartered, and we focus quite a bit of our attention on national public policy. I will tell you this, we have not done a single good thing in healthcare at the national level in Washington in the last decade, and we probably won't for another decade. Nothing good is happening in Washington when it comes to healthcare policy. Amazing things are happening, though, at the state level. And we're seeing that both in pharmacy, in medicine, in every area. So our focus is on, in our states, where we look at our colleges of pharmacy, our state pharmacy boards, and our state pharmacy associations working together to advocate for change in healthcare, specifically change on the pharmacy side of delivering healthcare at that state level. We're finding an awful lot of very influential opportunities for both faculty and, I would argue, students to be involved and more involved in advocacy efforts. When you think about advocacy, one of the things you should be thinking about is you as a demography, you as a demographic. There isn't a politician in the United States that doesn't want to talk to you and your people of your age and your demography to say, I need your votes. So if you want to argue a point and advocate for a position, you put a load of pharmacy students in a bus with their faculty, with state association, their state boards, you drive them to the state house, you're going to have influence. It's a powerful, powerful amount of influence that can be exerted, and we're working very hard to push that agenda forward with our state associations and our state boards, as well as their national associations that represent them. We're moving in pharmacy towards more of a competency-based education framework. This is a non-time-based structure where it doesn't say you'll be involved in care for 4 years, but rather you're going to get your degree as quickly as we can get you competent to practice. So when you think about driving a car, did every one of us learn how to drive a car at the same rate? Are there skills we had, parallel parking, that we all learned at the same rate? No. Why would we think that we can give individuals the skills they need in 4 years and everyone will track exactly the same way? Most other disciplines, medicine, nursing, and veterinary medicine, dentistry, are very much ahead of pharmacy in driving a competency-based framework, and we're working very hard to make that happen for pharmacy as well. So that pharmacists who will make great pharmacists but struggle in a particular area won't be held up for multiple years or be kicked out of pharmacy school because of one particular skill that just takes them a little while longer to achieve. Similarly, when we look at the amount of time that someone takes, maybe they have a terrific background and a previous degree in an area that's relevant to pharmacy, maybe they can get out of pharmacy school in less than 4 years. We should be aware of that and able to manage that kind of thing. This has a particularly important emphasis when it comes to diversifying our workforce and diversifying the pharmacy student body. That when we look at students who are coming from areas without great public education through high school, there are a lot of students that will make great pharmacists, students of color that would make great pharmacists. They just don't have the background from their high school training to do it in 4 years. Competency-based education allows us to bring a greater level of diversity to our student body, giving people who wouldn't have had a chance to become a pharmacist because they couldn't do it in 4 years, a chance to make that happen. So this is a huge area for us, huge area of emphasis in the Pharmacy Academy moving forward. We're working on expanding our membership within our association, in particular, in engaging our pharmaceutical scientists at a different level and a greater level so that we can continue to support that group of faculty at our schools, and moving forward through expanded research opportunities, both intramurally at AACP and as a convener and an advocate for research that's happening in our colleges of pharmacy with those individuals. We're also working very closely with a number of different global international healthcare organizations and pharmacy organizations to identify ways that we can expand our global presence as an academy in the United States. And we have a new agenda moving forward to expand our role in global health as a pharmacy association in the United States. So I went through quite a bit there. Hopefully I gave you a sense of kind of what's happening in pharmacy education today from the standpoint of a national pharmacy association that represents our schools of pharmacy. And I think we can open it up to discussion and questions.
I learned a lot because I know October is Pharmacist Awareness Month
It is.
and Pharmacist Appreciation Month.
Indeed.
And I want to welcome, wow, this is a crowd. This is probably the biggest crowd we've had.
Is that right?
Live crowd. Yeah. So welcome.
Hope I didn't disappoint.
And no, you did not. And I want to welcome all of our Zoom participants and let them know that if you guys have any questions, please put them in the Q&A and I will get to them. And all of you, our live audience participants, there are microphones on either side. If you have a question, please position yourself and we'll get to you. We already have 2 questions here. So we'll start with you. Go ahead.
Hi, Monica. Thank you so much. And thank you so much for speaking. I am not a pharmacist. I come more from the medicine and public health field. And this information is very interesting. And when you said that some of what was going on was a public health problem, of course, my ears perked up. And there was recently a story where their local Walgreens closed. And he said, I walk to this store every time to get my medications, and now I'm not going to know where to go and get my medications. And so my actual question though is, I'm just wondering if people have been thinking of different models of how to practice pharmacy. For example, one of our grads actually works at a federally qualified health center. But many federally qualified health centers and community health centers don't have pharmacists. And so I don't know if PharmDs are trained to maybe think of the business sense and to be able to approach community health centers to be able to help people that need it the most. The other thought that I had too was I was approached by somebody who is practicing paramedicine. So firemen, paramedics who go to homes and, they assess elderly patients for their fall risks and everything. And she was saying, it would be great if we could have a pharmacy student come out with us and, do, house calls on these folks. And it was difficult for me to get pharmacy students to go out with her. So I thought that would be a great opportunity for, a CVS or a Walgreens or something to be able to get one of their pharmacists out actually in the community and bring the medications to that person that may not have the capability to even get to the pharmacy.
Yeah.
So just wondering about the different models that that you're thinking of that are kind of on the horizon, maybe for the folks who are sitting in the audience today.
Sure. Yeah. Thank you. Yeah. I mean, so lot to unpack there, I guess. When we talk about community practice, thinking about pharmacies, so these retail outlets where they're filling prescriptions and they're caring for patients, that represents about half of graduates, about 45%. But there is a huge role for pharmacists today in ambulatory clinics and in federally qualified healthcare centers, and a wide range. Public Health Service has a huge number of pharmacists working in areas of medically underserved patients and doing remarkable things. So that path is absolutely there and has been for decades, and we need to continue to enhance that. What we're seeing overall in terms of our workforce is a decline in the number of pharmacists in those community pharmacy settings. We're starting now, though, to also see a decline in the number of graduates that are available to go into those other settings, but the opportunity is absolutely spectacular. I would say on the home care side, not only for an emergency care, but I know we have a lot of pharmacists that will graduate, go into critical care, whether in emergency medicine or work in an intensive care unit, working in that critical care setting. I'm an EMT myself, in fact, and this is something that I think would be, I agree, a great opportunity. But getting back to that notion of getting into the home, and this is something that I think isn't unique to pharmacy. I think all of us in healthcare need to think about not having patients coming to our clinics, coming to our hospitals, coming to our pharmacies, but rather us going to them. Ample evidence that we can change the direction of a patient's health when we see how they're living their health. And a pharmacist to go along with a nurse and a physician or a physician extender could change the nature of a patient's life. And I think that's something we've got to continue to work on. There are models out there. The VA's model, I think, is a really robust one where they send providers out to veterans' homes. And they're not just dealing with their healthcare issues, they're dealing with their psychosocial issues, they're dealing with their food insecurity, they're dealing with so many things that we can't change the healthcare trajectory without addressing those kinds of things. So that's something I think for all of us to think about, for sure. Thank you.
So my name is Patria Kober, and I'm a professor in the Department of Pharmacy Practice. And I attended a session this summer at AACP on competency-based education. And recently, as I'm getting more educated myself, I was in an assessment course that I'm taking, and we talked about competency-based education versus standardized, more formal, traditional processes. And being an RPD for 10 years, I realized that we want to move towards this competency-based education, but in the same effort, the recommendation form for a residency from ASHP states the first question, please compare this candidate to their peers and tell me if they would be in the similar, advanced, or below their peers. So how do we advance this competency-based education to postgraduate training and not compare all the time to our peers?
Yeah, that's a really important point and a very good one. So thank you for bringing it up. You know, when we look at other disciplines, our association belongs to a group called FFIP. It's the Federation of the Associations of the Schools of Health Professions. So in medicine, it's the AAMC, the Association of American Medical Colleges, as well as AACOM, the Colleges of Osteopathic Medicine, American Association of College of Nursing. There's about 14 of us that operate associations representing the schools of the health professions. And we have this discussion, this very discussion, and we're seeing it universally. There are so many postgraduate influences or phenomena that we have to change in order to make competency-based education happen. But it has to start with us. Right now in medicine and nursing, in dentistry and vet med, they're embracing this idea of not being time-bound, not being rigid in their curriculum, not saying, well, if you fail one class in your second year, you've got to basically wait a whole year to get back on cycle. And we have to get over that ourselves. As we talk with ASHP, which is the American Society of Health System Pharmacists, they accredit residency, postgraduate residency training. They're ready to change. They're willing to make changes, but they're not going to make any changes until we start changing in the academy. So that's the direction we're heading. We also have to make regulatory changes. We have to make accreditation changes so that our colleges of pharmacy are accredited not on the basis of do you get your students out in 4 years, but rather are you putting out a high quality product? ACPE, which is the Accreditation Council for Pharmacy Education, they are our accrediting body. They accredit you and they accredit our other 142 colleges of pharmacy. They're ready to make that change as well. So we have to change some mindsets. There's an awful lot that goes on historically that will have to change as we move towards competency-based pharmacy education. Thank you for bringing it up.
You brought up a great couple of points about the big pharmacy chains and the environments that the working conditions that these folks have to work in. What are they doing to improve the situation? And what are they doing to recruit?
Well, not as much as we'd like them to do, actually. They are changing things like quotas for the number of prescriptions that a pharmacist has to fill in an hour. They're doing that largely because pharmacists are saying I'm not able to care for my patients safely with these kinds of quotas. So not every one of those corporations is changing at the same pace, but they all recognize that their fundamental business model is in jeopardy because people don't want to practice in that setting. And when you look at something like a CVS, now you have to recognize CVS isn't really a pharmacy. They're an insurance company. They own Aetna. So when you think about their whole business venture, their business model, they're an insurance company that happens to run some pharmacies. But the rest of pharmacy practice in the community setting, in the corporate world, are seeing this as a fundamental, threat to their business model, and they're working very hard to change. We're helping them by identifying models that are going to help them make a better business, make, like as I mentioned, a shift from being a provider of a product to provider of care, and helping them understand how we can make that be valuable to patients, valuable to insurers, valuable to public payers like Medicare and Medicaid. So those are things that we're trying to work with them. They're moving not as quickly as we'd like, though. So we're continuing to nudge them forward.
What's the answer? I mean, if we're in a shortage, they're going to close. We just saw a number of Rite Aids close.
Well, yes.
And
Rite Aids, Walmart, Walgreens will be closing about a quarter of their stores over the next 6 months. We're going to be seeing pharmacy deserts. We're going to be seeing a lot of health declines, I think. When you think about the way public policy has worked around healthcare in our country, a lot of change is driven by finance. How do we pay for it? So I think what will really move the needle is as we start to see patients' health decline, see ER visits, hospitalizations increase because they're not receiving the chronic medication therapy that they need, and the result is worse health outcomes. We start to see the costs of those things. People will say, oh, wait a second, maybe we need to invest in pharmacy. And that investment needs to be in not paying for a medication, but paying for the care the pharmacist gives that patient when they come in to get their prescription, whether it's in vaccines or it's educating them on self-care medications that they're using, or it's educating them on lifestyle. These are the things that pharmacists are bringing. I think something, as with many crises that we face in our country and around the world, something bad has to happen before we start to see change. The bad thing that will end up happening if we don't turn this tide around more quickly is that costs will rise because we don't have enough pharmacists caring for their patients.
so how does that recruit students into pharmacy schools?
Well, so what we are trying to do is point out and show pharmacy students, or pre-pharmacy students, high school students, middle schoolers, a practice that is changing the health of their patients. Give them the kind of experience in seeing a pharmacist caring for patients that I got when I started and when I decided I wanted to be a pharmacist. So those are the kinds of things that the practice model will change as we're pushing that agenda forward, and they'll see a better world. We're doing other things to encourage young people to think about going to pharmacy school, showing off not just the practice in the community setting, but practice. Pharmacy is an incredibly versatile degree. You can go into a lot of different areas through their pharmacy degree. So we're showing off those very, very diverse career paths as well.
Right.
Yeah.
Thank you for your talk today. Question, looking at your background, you came to AACP as a bit of an outsider, right? Had roles that were faculty adjacent, probably more than knee deep in it. But for those of us here in academia all the time, I feel like we tend to develop some blind spots. So as the sort of outsider coming in to this role in AACP, what did you see as academia's biggest blind spots and threats we weren't paying attention to?
Yeah. I actually did teach. I'm not unfamiliar with the classroom. I spent 20 years at the University of Wisconsin and taught in drug literature evaluation and drug policy. When I got to Kentucky, I was really shifted more into health system administration. But it's true, I had never gone to an AACP meeting until my very first one as CEO. So I had my badge on with the board of directors and first timer, which was kind of weird. It was really kind of awkward, actually. But I think our board saw me as a candidate that could bring a very different perspective to the academy. I think there are several things that I've observed in the last couple of years. Well, first of all, let me tell you, I got the coolest job on the planet, without a doubt. I'm absolutely honored to be serving the Pharmacy Academy. And when I went to my first AACP meeting and I learned about and met hundreds, thousands of pharmacists and pharmaceutical scientists that educate, I learned, I was home. This is it. There are amazing things that our pharmacy faculty do, our pharmacy students do. But there are also some things that perhaps I think our faculty have been a little isolated and insulated from. The realities of running a healthcare system when you're at that sharp end of the stick, where a decision you make in the morning affects the health and the outcomes of patients later that day in a health system. We don't operate in the academy, and I don't think this is just limited to pharmacy. I think this would be true across healthcare. We have the luxury of being able to take our time and think and talk and debate. And that's fine. And we should cherish that and relish it. But at some point we have to make decisions. At some point we have to move, and we have to move quicker. Healthcare moves just too quickly today to debate for the length of time that we do. Now, my biggest challenge is in tapping the brakes, and my board of directors nudges me and said, "Lee, tap the brakes. We're not, you're out beyond the end of your skis right now, so bring it back in a bit." But we can still move faster. I think there are opportunities when it comes to demonstrating the value of what pharmacists and pharmacy faculty do. The ability to look at a program and say, this has the opportunity to bring revenue into a college of pharmacy, as an example. When we discharge patients, when I was at the University of Kentucky, spent a lot of time dealing with patients coming from Appalachia, coming from areas where there were no primary care doctors. My first couple of months at the University of Kentucky Healthcare, UK Healthcare, and the Chandler Medical Center, I would look at our patients' records and see, hey, you don't have a primary care doctor documented. Is somebody not entering that? Oh, they don't have a primary care doctor. They're in Perry County, Hazard, Kentucky. There are no primary care doctors there. There's a Walgreens there, though. And I said, well, this is an opportunity. This is a chance for patients who are being cared for in the academic medical center, being discharged back to home, not to a pharmacist, not to a nurse. The only person we're discharging that patient back to is their pharmacist. I got pharmacists caring for those patients. I got pharmacy students caring for those patients when they're in the hospital. I've got pharmacy faculty, adjunct faculty as preceptors at that Walgreens, and I have student pharmacists working in that pharmacy. So why don't we connect the pharmacists and the student pharmacists together for that transition of care? The objective being keeping the patient from coming back. Think of every hospital you've ever been in, every academic medical center you've ever been in, the coin of the realm. If you want to make your CEO happy in those hospitals, decrease their readmission rate. Decrease their readmission. You want to know why we had such a terrible readmission rate at Kentucky is because we sent our patients home to nothing. Sure enough, 3 weeks later, that patient who we just put a $75,000 new kidney into is back in my hospital as a readmission because they got no post-discharge care. It didn't happen. So I offered this. I said, we'll pay for that pharmacy student and in both the hospital and in the community, and the faculty who are working in those areas. We'll pay the College of Pharmacy to create this program. That's the kind of model we should be looking for. These are models that pharmacy faculty traditionally haven't thought through, the value of what they represent. So these are some of the things that I'm seeing and I'm trying to encourage our faculty to take it, to embrace. And I think they're going to create great learning models. And I also think they're going to create great practice models for our profession.
What should undergraduates know about the process of preparing for pharmacy school admission?
There's a lot to know. I mean, it's just like every other health discipline. Pre-pharmacy training is rigorous. Most of our colleges of pharmacy require about 70 hours of undergraduate training of pre-pharmacy work. However, about 65% of our entering classes have a bachelor's degree before they come to pharmacy school. So there is an awful lot that goes into that background work. I would say, for most of the time when we're in the process of recruiting and we're thinking very hard and doing a lot of work, thinking about how do we get that message to people who are interested in healthcare and then hopefully interested in pharmacy is, focus on sciences is a really critical part, just like it is in medicine and other health disciplines. But we also encourage people to spend some time in a pharmacy, in a community pharmacy, in a hospital setting, in other settings. I think that's a really critical thing that will really set the hook when it comes to getting a young person's interested in becoming a pharmacist.
How much should they know about insurance? How much should they know about math?
Well, I wish we didn't have to know anything about insurance. I think math is one thing. Pharmacy, like medicine, is a very highly mathematical focused practice and degree. I would say insurance, this is something though, whether they need to know it coming in. One of the things that I think is another unique aspect or unique feature of a pharmacist is their understanding of the business of healthcare. And when you talk to a lot of physicians or nurses They have an understanding of billing. They have an understanding of certain aspects of the business of healthcare. But pharmacists have always historically been intimately engaged in the thought of, well, how do we pay for healthcare in our country? The more we see pharmacists in academic leadership roles, in health system leadership roles, like I fell into that because of my understanding of the dynamics of insurance and the dynamics of funding healthcare. So I think it's a great thing if they have that coming in, but hopefully at some point we won't have to be quite so focused on insurance necessarily.
I want to encourage our Zoom participants. Don't forget, you can ask a question of Lee and just put it in the Q&A and I'll get to it. And our live participants, we have another question up here.
Hi, can you describe some of the barriers in our curriculums and public policies and the changes that could be made to make it so that more recent grads are more likely to become independent pharmacists in Ohio?
Yeah. Well, there's a couple of things, I guess. When I was a pharmacy student, we spent, I think, more time than we do today in the curriculum on the business of healthcare and understanding how money flows. I mentioned curricular overload as a challenge. Unfortunately, over a couple of decades, as we started to move more clinical content, more scientific content into the curriculum, we were forced to remove some things. And a lot of colleges of pharmacy decided to remove those business of pharmacy aspects, which is unfortunate and something we should really start to think about. I think though, when I think about the value that pharmacists, and not just pharmacists, healthcare professionals play in public policy, it's at that advocacy role. It's being able to recognize an opportunity where a community can benefit from the care they're going to get from a pharmacist, from a public health nurse, from a primary care physician. Understand that value and be able to translate that value clinically into the value, the what's in it for me. For who? For insurers, for legislators, for employers. Think about this. Over half of the healthcare budget in the United States is paid for by employers today. Federal government, Medicare, Medicaid, state governments with Medicaid and shared with Medicare, or Medicaid's a shared federal state program. The public funders are less than half of the country's spend on healthcare. So I want to be able to articulate to a big employer, hey, you know what? Pharmacists are keeping your employees healthy, keeping them on the job, keeping them in the workforce, keeping them productive. And then you start to see employers' eyes light up. Oh, if they're healthier, they're more productive. Well, now I'm getting something for the money I'm spending on health insurance premiums. Pharmacists, and again, I'm not going to limit it to pharmacists, healthcare professionals need to be able to articulate the value they provide in ways that are different from, I saw 10 patients today, I filled 275 prescriptions today. Think of the outcome of the care you're delivering and be able to articulate it. We need to help you. And part of what we're doing, as I mentioned, I don't think much is happening of any value in Washington today with respect to public policy. But we should be helping our colleges of pharmacy, our colleges of medicine, our colleges of nursing, colleges of dentistry, articulate that value and understand how to teach it to students so that they can be empowered when they reach, not even before they reach practice, as students, but then as new practitioners and lifelong practitioners, to be able to go to a legislator and competently and confidently say, we need to change whatever it is you need to change. There's a lot we need to change. There's a lot of regulation that in pharmacy that we need to get out of. There's only one profession in all healthcare that's required to pass a jurisprudence examination before they practice. It's pharmacy. Why? It's crazy. So we're working towards getting rid of that. I know there's some controversy around that in Ohio today, but in other states, they've done it. And I think that's something we need to be able to teach a pharmacy student how to express their feelings about the need to do a jurisprudence examination, let's say, so that you can be advocates for our profession and for the patients that you're going to be caring for. So that's my story.
Thank you.
Sure.
I guess I'll go first. Thank you for all of your insights so far. I just had a quick question regarding interprofessional education. It's such a buzzword now. The work that I do in education and in healthcare quality improvement, you hear from universities that we need more interprofessional education, and from the clinical side, people say we need more interprofessional teams to provide holistic care for patients. I think a lot of times when we talk about interprofessional education and care, it stops at the rudimentary level of, well, the physician needs to talk to the pharmacist. The projects that I've done and the things that I've done in healthcare seem like there's a lot more complexity to that, right? You need the quality improvement engineers, you need the nurses, you need the physicians, you need the, so I was wondering if you could talk a little bit more about what you see as the ideal state of interprofessional education and care, and where universities could maybe help prepare for what we're striving to do in that realm.
Yeah, it's a great topic, and I should have included it in my slides, so thank you for bringing it up. Interprofessional education, it saddens me that it's a buzzword, frankly. It saddens me that it has to be a buzzword, because it shouldn't be a buzzword at this point. Medicine, nursing, pharmacy, dentistry all have accreditation standards that focus on interprofessional education. We have an interprofessional education collaborative. So all of those associations that I mentioned before all get together to talk about how do we enhance our members, our colleges of medicine, colleges of pharmacy, colleges of nursing, our interprofessional education. But you know, the problem we have with interprofessional education is that we're not doing it in practice. It has to become an expectation of employers, of the healthcare delivery system. When I was in Kentucky, and even before that, when I was at Wisconsin at UW Health, my teams, I ran interprofessional teams in efficiency and in service lines and in quality improvement. You don't change quality without involving all disciplines. And I love that you mentioned healthcare engineers. Human factor analysis, huge opportunity for us, not only to improve quality, but then to see costs reduced because the quality is improved. We have to make that the norm. And it's not about a pharmacist talking to a doctor, or a pharmacist talking to a nurse, or a nurse talking to a doctor. It's about the team and recognizing the contribution that everyone makes to our patients, not my patients, our patients. Until we get our healthcare systems to recognize the importance of it. And this is another one of those sales pitches that I'd love to give to health systems around the country. You want to make yourself more efficient, make sure that you don't do anything without a team doing it. And, you know, when you think about not just the outcome for the patient, if you want to look at data on turnover in health systems today, in teams, so the swirl, so I may have stayed at that health system, but transitions from one team to another, you want to see the lowest, we call that swirl, when they go from being a neuro nurse to being a critical care nurse in an ICU. You know, that's that swirl. They stayed in the organization, but they just moved to it. You want to find the lowest rates of attrition, lowest rates of turnover, lowest rates of swirl is where usually physicians have led it and said, I'm not going to care for a patient. I'm not going to start rounds until I have my team here. Lowest rates of turnover, highest quality outcomes, lowest possible cost. Once we find that happening, the academy's ready to do it. The challenge I think we have within education is that we do it, and then they go out and they don't see it. They don't practice it. It's not what they do. So I'm not blaming healthcare delivery systems for this, but I think we're going to be really, really challenged to make interprofessional education successful until it's the expectation of the practicing of healthcare delivery systems that they're going to know how to do it when they get there. But that's our hope.
Hi, Jackie Boyle, College of Pharmacy. Thank you so much for your speech today. I've seen you speak many times, and I know you are a futurist about a lot of topics in healthcare, specifically pharmacy, obviously. But I'm wondering, you know, we have all of our pharmacy learners here today. We may have some learners online as well. What's the number one piece of advice you would give them to think about during their training, both now and what they can do in their curricular activities, but also after graduation? Thank you.
Thanks. You know, I don't know if this is going to be the best answer, but what I'm starting to sense, and as an outsider coming into the pharmacy academy and being in this role, I pay a lot of attention to kind of the tenor of the student body nationally. And I see a lot of discouragement. I see a lot of a lack of optimism. I see a lot of people questioning their decision to become a pharmacist. So the first thing I would say is, don't lose your optimism. You made an amazing choice going to a college of pharmacy, an amazing choice. I've talked all about problems today, and I'm sorry for not being as optimistic as I probably should be. I don't think there's a better time today to be a new practitioner in pharmacy. The kinds of things that we're going to do in the next decade together with physicians and nurses and other healthcare professionals is going to be amazing. We're going to be caring for patients in ways that we never thought we could. We're going to be driving primary care in settings and in communities where they don't have access to care. So my biggest advice would be, stay optimistic. You know, it may look bleak today, but it is not going to be bleak long. You know, I encourage students to focus, like we were talking about earlier, focus on issues related to the business of healthcare. So much of what we do is driven by the cost of care. Think about public health. The first question. Think about the role of pharmacists in public health. And because that helps get you out of the mindset that my job is to dispense a medicine. Now, let's not lose sight of this, though. Pharmacists are the stewards of the medication use process. Our first responsibility is to make sure that the patient gets the right med at the right time, at the right dose. We cannot lose that fundamental responsibility. That is on us, but it can't stop there. It has to go into these other things. And that's where we're finding practice enhancement. That's where we're finding excitement again in our profession. So I would say to focus their attention on not just those aspects of care delivery that are focused on the product. They have to understand that. They have to look at the other side too. That's probably my answer.
We just have one final thought for
Okay.
you. The state of Ohio, is there anything you would encourage students to do, to change, to push for?
You know, I think I view Ohio as a fairly progressive state. And I know there are challenges in Ohio, but I think you have amazing colleges of pharmacy here, including this one we're in right now. I think you've got amazing leadership at your state associations. I think your state board, while they may be dragging their feet a little bit here and there, they are a progressive board. When you look across our country at boards, they are progressive. So I would say the idea behind advocacy would be to create the vision for the future and articulate it to those who are making decisions for you. I think Ohio is ready for a really amazing future. And compared to some states where I don't see as much opportunity, I think you have it in Ohio. And I think there's great opportunity coming.
Thank you so much. Would you please give him a round of applause?
Lee, thank you for an absolutely amazing discussion. We learned a great deal about the work the AACP is doing to advocate for improvements in education and training in pharmacy. Monica, thank you, as always, for your expert moderation. Please join us next month on October 10th for VITALS, when we will hear from Scott Becker, the founder and publisher of Becker's Healthcare, the go-to national platform for health system leaders on discussions and topics in healthcare operations. Until then, stay active and stay engaged. Thank you.
This is VITALS, Visionary Health Leadership in Action.